Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is ready. Just sign here. I used to believe that too, until I started counting the patients who went in for routine procedures and came out permanently changed. Not better, changed. A man who walked in with back pain and left unable to walk at all. A woman who survived open heart surgery but lost 6 months of her life to complications nobody warned her about. Here's what nobody tells you. The older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. My name is Dr. Kevin Adewale. I'm a cardiothoracic surgeon with over 2 decades in the operating room. And today, I'm going to tell you the truth about 5 surgeries that carry serious hidden risks for people over 60. Let me ask you something. If you take a brand new car and a car with 200,000 miles on it, and you put them both through the same stress test, do you expect the same result? Of course not. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery expectations, same timelines. That's starting to change, but not fast enough. Here's what happens inside an older body when it goes under general anesthesia. The heart has to work harder. The lungs take longer to clear the anesthetic. The kidneys slow down processing medications. And the brain, this is the one that surprises people. The brain becomes temporarily disoriented in ways that can last weeks or even months. Doctors have a name for it: post-operative cognitive dysfunction. And in patients over 70, it happens far more often than anyone admits. Now, I want to be absolutely clear about something. Age alone is not a reason to avoid surgery. I have operated on 80-year-olds who bounce back faster than some 50-year-olds. Age is just a number, but frailty is not. Frailty is a medical term. It means the body's reserve has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That number jumps to nearly 60% over 85. So here's the real question. It's not whether someone can survive the operation. It's whether they can survive the recovery. Those are 2 very different things. And that distinction is going to matter a great deal right now. Surgery number 1. Open heart surgery in frail patients. Coronary artery bypass grafting, CABG we call it, is one of the most common major surgeries performed on older adults. The idea is simple. Your arteries are blocked. We reroute the blood flow. And for the right patient, it works beautifully. But here's what the brochure doesn't show you. Open heart surgery requires stopping your heart completely. We put you on a bypass machine, a device that does the work of your heart and lungs while we operate. For a 60-year-old in good shape, that's manageable. For a 78-year-old with kidney disease, mild diabetes, and cognitive decline, that bypass machine is a serious assault on every organ in the body, simultaneously. Studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications. Stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here's something that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this surgery. So what's the alternative? In many cases today, there is one. It's called TAVI, transcatheter aortic valve implantation. A catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic than surgery, but far kinder to a body that needs kindness, not a battle. Does this mean you should refuse heart surgery? Absolutely not. It means you should ask your surgeon one question. Am I a candidate for a less invasive approach? That question alone could change everything. Surgery number 2, aggressive spinal surgery. Back pain in your 60s and 70s is almost universal. I don't know a single patient over 70 who hasn't mentioned their back. And the solution that gets offered more and more often is spinal surgery. Fusions, multi-level decompressions, hardware inserted up and down the spine. Now I need you to hear this clearly. Some spinal surgeries are absolutely necessary, no question. A spinal cord being actively compressed, causing loss of bladder control or paralysis. That needs surgical intervention immediately. But elective spinal fusion for chronic back pain in an elderly patient? The evidence is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. 40%. And the most common complications weren't minor. Blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion start breaking down because the mechanics of the spine have been permanently altered. The hardware holds one section rigid, and the rest absorbs the price. And here's what frustrates me most: the pain relief. Studies show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better, but with dramatically higher risk. I had a colleague, a brilliant spine surgeon, who once said to me, "Kevin, sometimes the best operation is the one you don't do." I think about that a lot. Have you ever been told surgery was your only option for back pain? Write that in the comments. I want to know how many of you have heard those exact words. Surgery number 3. Major cancer resections. This one is the hardest to talk about, because when someone hears the word cancer, the instinct is immediate and powerful. Cut it out. Remove it. Get rid of it. And I understand that completely. I would feel the same way. But here's what 2 decades in surgery has taught me. The goal of treatment is not just to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the opposite. Let me give you a real example. Pancreatic cancer surgery, the Whipple procedure, is one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The surgery itself takes 6 to 10 hours. In younger, healthy patients, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away within weeks from surgical complications. Not from cancer, from the operation. This is called futile surgery, and it is more common than anyone wants to admit. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced failure to rescue, meaning a complication occurred that the weakened body simply could not survive. So what's the conversation worth having? Ask your oncologist this question, and ask it directly. If we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health status? That question opens a door many patients never even knew existed. And sometimes, the answer behind that door is genuinely better. Surgery number 4. Elective joint replacement in severely ill patients. Hip and knee replacements are among the most successful surgeries ever developed. I say that without reservation. For the right patient, a new hip genuinely transforms quality of life. People go from barely walking to playing with their grandchildren. It's remarkable. But here is where it gets complicated for older adults. The word elective means the surgery is planned, not emergency. You have time to think. You have time to prepare. And crucially, time to ask whether this is the right moment for your specific body. Because here's what the statistics show. In patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries significantly elevated risk of perioperative complications. Blood clots are the biggest danger. Deep vein thrombosis, clots forming in the legs, can travel to the lungs and become life-threatening pulmonary embolisms. In elderly patients with reduced circulation, this risk is substantially higher than in younger patients. Add post-operative pneumonia from lying still too long. Add hospital-acquired infections, and the picture becomes much more complex. I want to be precise here, because I don't want to frighten anyone away from a surgery that might genuinely help them. The question is not, should I ever have a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular health before elective surgery can reduce complication rates dramatically. Some hospitals now require a formal prehabilitation program before they'll schedule these operations for high-risk elderly patients. And that is exactly the right approach. Has your doctor ever discussed prehabilitation with you before a planned surgery? Most people have never even heard that word. and they absolutely should. Surgery number 5, emergency abdominal surgery. Now I need to pause here for a moment, because this one is different from the others. You don't choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding. These situations don't wait for a calm conversation in an office. But here's why it belongs on this list. Knowing the risks in advance, before the emergency happens, changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We're talking 30 to 50% in the most severe cases. Not because surgeons aren't skilled, but because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, kidneys, heart, lungs, they all get hit simultaneously. And the inflammatory response that a younger body controls within days can spiral in an older body into something called systemic inflammatory response syndrome. When multiple organs start shutting down in sequence, it is as serious as it sounds. So what can you actually do with this information? 2 things. First, do not ignore abdominal symptoms. Persistent pain, bloating, changes in bowel habits in someone over 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies. That one habit can change everything. Second, have the conversation with your family now. Not in the hospital corridor at midnight. Now. What are your wishes if emergency surgery is the only option? What quality of life matters to you? These conversations are not morbid. They are one of the most loving things you can do for the people who will be standing in that corridor. All right, we've covered 5 surgeries. Now let's talk about what you actually do with this knowledge. Because information without action is just anxiety. And that's the last thing I want for you. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. Write these down. Question 1. What happens if I don't have this surgery? A good surgeon will give you an honest answer. If the answer is, nothing urgent changes in the next 6 to 12 months, you have time. Time to think. Time to get a second opinion. Time to optimize your health. Question 2. Is there a less invasive alternative? Medicine has changed enormously in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that didn't exist a decade ago are now available in most major hospitals. Question 3. What does recovery realistically look like for someone my age and my health profile? Not the average patient. You, your heart, your kidneys, your current medications, your living situation. The answer should be specific, not generic. And question 4. This is the one most people never ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If they seem uncomfortable with the question, that itself is information worth having. Before I get to the most important part of today, I want to leave you with something genuinely hopeful, because this is not a video about fear. It's about options. And those options have never been more powerful than they are right now. Minimally invasive surgery has transformed what's possible for elderly patients. Laparoscopic procedures, small incisions, camera-guided, dramatically reduce recovery time. Robotic-assisted surgery allows precision that human hands alone cannot achieve. And catheter-based cardiac interventions have opened doors for patients who would never have survived traditional surgery. Beyond surgery itself, and this is something I wish more patients heard, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to require a knife. The body wants to heal. Sometimes our job as surgeons is simply to get out of its way and give it the tools it needs. I want to tell you about a patient. I'll call him Gerald. 71 years old, retired engineer, sharp as a tack. He came to me after 3 different surgeons had recommended open heart surgery for a blocked coronary artery. 3 surgeons, 3 recommendations. Same answer every time. Gerald wasn't afraid of surgery. He was afraid of losing himself. He'd watched his wife go through a major operation 2 years earlier and come out confused, exhausted, and never quite the same. He told me, Dr. Adewale, she went in as my wife and came out as someone I had to take care of. That sentence has stayed with me ever since. When I reviewed Gerald's full profile, his kidney function, his frailty score, his cognitive baseline, I sat down with him for 40 minutes. Not 15, 40. And I told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehabilitation. The data for his specific profile showed comparable 5-year outcomes between the two approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He's standing at the top of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he won the lottery. Here is what I need you to understand. This is the single most important thing I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you have the right to ask every hard question, to request every alternative, and to take every day you need. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine. More powerful than any operation I've ever performed. Let's bring it all together. 5 surgeries that carry serious hidden risks for people over 60. Open heart surgery in frail patients, where less invasive alternatives now exist. Aggressive spinal fusion, where evidence for pain relief is far weaker than most patients are told. Major cancer resections, where the goal must always be more good years of life. Elective joint replacement in severely ill patients, where timing and preparation matter as much as the surgery itself. And emergency abdominal surgery, where the best protection is catching problems early and having honest conversations with your family now. None of this means avoid all surgery. Surgery saves lives every single day. I have seen it. I have been part of it. I am proud of it. The message is this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and if necessary, a third. Your age is not a weakness. What question would you most want to ask your surgeon before a major operation? Tell me in the comments. I read every single one. And if this video helped you or someone you love think more clearly about a surgical decision, share it. That one share might be the most important thing you do today. Take care of yourselves. Stay curious. Keep advocating for your own health. You deserve a surgeon who explains everything, and a medical team that treats you as a partner. And one last thing. Everything I've shared today is general medical information based on published research and clinical experience. Every person's situation is